Hey everybody, this is Mrs. Poindexter here, and we're just going to go over a short overview just to clear up some things when we talk about diabetic ketoacidosis, or DKA. Again, a big thing I always stress is just look at the name. So we're talking about diabetic ketoacidosis. So when we look at the name here, we know that it happens with our diabetics. Keto, there's going to be ketones, and we're going to have a problem with acidosis. Okay, so diabetic ketoacidosis is defined as an absence or a significant inadequate amount of insulin. Those affected are going to be primarily your type 1 diabetics and sometimes newly diagnosed type 2 diabetics. The second is a little bit more rare. A lot of our type 1 diabetics are typically diagnosed through a case of DKA. Additional complications that we may see that precipitate DKA is infection, trauma, increased stress, and non-compliance. So we'll have some type 1 diabetics who are non-compliant, or they may have an infection, or have suffered some sort of trauma, or have an increase of stress, and they are not adjusting their insulin to meet these demands upon the body. So when we have a patient in DKA, there are 3 issues that we need to address. Number 1, the metabolic acidosis. Number 2, dehydration. And then, of course, number 3, the hyperglycemia. So again, just to talk about why DKA happens, and we'll look at specifically with our type 1 diabetics. And let's see how well this works here. So remember when we talked in class that we have the bloodstream. And remember, with our type 1 diabetics, their body does not produce any insulin whatsoever. So the body is having to rely upon the human for its insulin, which obviously humans aren't always reliable. So right here, these are going to be our cells. And here's the problem, and like I've talked about before, we can kind of pretend like this is the brick wall in between the two. And the problem is that the cells have absolutely no idea what is going on in the bloodstream. And so what we have going on over here is an abundant amount of glucose going on. But here's the problem. So you have our cells, they are starving. So when the body cannot meet the demands of the cells, so let's say somebody's in trauma, the cells are overworking, and so their energy level has depleted, so they need more glucose. But if the body is not getting the proper amount of insulin, the cells are unaware of this, and so they will send a message to the body to kind of go into Plan B. And Plan B entails to start breaking down other parts of the body for energy. This includes fats, which the big component of fats byproduct are going to be the ketones, which unfortunately ketones is an acid, SICID, which of course leads to our acidosis. What happens at the same time when there's acidosis? The increase of acid increases the hydrogen atoms, and then what happens during that time is that hydrogen atoms and potassium are going to kind of do a do-si-do. So potassium is going to leave the cell and exit, while the hydrogen atoms go inside. So what is also possibly going on with the patient DKA is a rise in serum potassium levels. But at the same time we have this breakdown, so we have the acidosis, and we have more energy going on, and unfortunately in the end the cells are still starving. So this is a lot of what's going on. So this is where you get your ketones, which is going to be from plan B, because the cells are still starving. They don't recognize that the bloodstream is flooded full of glucose, so we have hyperglycemia levels higher than 250 of the blood glucose. We're going to have some elevated potassium. So these are going to be our problems. And because of osmotic diuresis due to the high level of the blood glucose, patients are also going to have problems with dehydration. So we're going to have signs and symptoms of fluid volume deficit. Okay? Hope that all makes sense. Moving on. So the symptoms, like I said, we're going to have hyperglycemia right here. We're going to have levels higher than 250. Because of the breakdown of ketones increasing the acid, we're going to have a pH level less than 7.35 because this patient is going to become acidotic and will be positive for serum ketones. There's your acidosis, and the compensatory mechanism to metabolic acidosis in terms of the increased level of the ketones is through the respiratory system. So a patient will experience the Kussmaul respirations. They will have that acetone breath, which can also either be described as fruity or like nail polish remover. Metabolic changes, the one that we're going to be most concerned with is going to be the increase in potassium due to its effect on muscle excitability, in particular cardiac. A lot of the signs and symptoms with the osmotic diuresis is going to be your polyuria and polydipsia. Also with fluid volume deficit, with weakness, malaise, the blurred vision with the hyperglycemia, hypertension with the fluid volume deficit, warm dry skin, decrease in skin turgor, the flat neck veins, the dry mucous membranes, anorexia, the nausea, vomiting, and abdominal pain can be more contributed to either the acidosis or in some cases the high potassium levels, dehydration, mental status changes, coma, and death can result due to all the changes of either going into shock or the acidosis. So there's a lot of things going on, and of course we certainly do not want our patients to get to this point. Treatment, like I said, there's 3 issues we have to deal with. If you went back to the beginning here, just so you can see, is we need to address the metabolic acidosis, the dehydration, and the hyperglycemia. Okay. So by addressing those, IV fluids, you want to monitor to avoid cerebral edema, just because of that quick reversal of fluid. We don't want the fluid shift to happen, which can also lead to hypovolemic shock. So you want to be cognizant to what's going on with the patient when you are doing the replacement. Normal saline is typically used. Insulin to help decrease those glucose levels, regular via IV is going to be the quickest way. Don't think of giving any patient anything sub-Q. Potassium replacement is going to be important, since potassium will be driven back into the cells using insulin. And of course, what was the reason that caused the DKA? So treat the underlying problem. Again, during all this, monitor your potassium and glucose levels. So down here, just to kind of reiterate what happens that I've drawn other times, is if this is the bloodstream. Wow, my writing is so terrible. But here's glucose, here is potassium, insulin. Like I said, I kind of call it the boat. It's going to sail the tube back into the cell. And so the thing you have to watch with that is, since we don't know how a patient's body is going to respond to this, that's why you need to constantly monitor both the potassium and the glucose levels. It is during this time when we're doing the rehydration that I've kind of used the illustration of a balance here, that we don't want the levels to drop too quickly, so that's why I want that constant monitoring. The rehydration helps with tissue perfusion for fluid that's been lost through the osmotic diuresis. Like I said, we'll always start off the normal saline at a rapid rate. And like I said, watch for signs and symptoms of the cerebral edema with change in levels of consciousness, and also watch for signs and symptoms of fluid volume excess. Again, take into account if the patient has any other comorbidities, like heart disease, pulmonary disease, those signs and symptoms like crackles, distended neck veins, edema, weight gain, shortness of breath, hypertension, and full and bounding pulses. Monitoring potassium, why? With the metabolic acidosis, it causes that shift of the potassium out of the cells in exchange for the hydrogen atoms. So you want to get a baseline EKG of this patient. When we're doing it during the insulin therapy, because again, during the decrease of the glucose levels, it can push potassium back into the cells. And so we want to watch that influx and make sure that the patient doesn't have a drop. And lastly, getting the lower serum glucose levels. So the reason why we want to monitor this is, yes, the goal is to get them down, but until the cells start getting glucose, the body will continue to break down fats for fuel. So while the fats are being broken down, their byproduct will continue to worsen the state of the metabolic acidosis. So correcting the high glucose levels in turn also helps reduce the metabolic acidosis. So again, this will be done through the regular insulin. And again, for the umpteenth time, make sure you're monitoring the patient's potassium and those glucose the serum glucose levels. And the big thing you need to watch, books will have a lot of different goal ranges. So in some readings it will say when levels start to reach less than 200. Some other readings have said less than 250. So that's why here I'm just using 200 to be on the safe side. But basically you will want to make sure to add some glucose to keep the patient's glucose levels from dropping too quickly and causing hypoglycemia. So this would be things like D5, normal saline, or you could use D5 half normal saline. Okay, so I hope that makes sense, because again, it's all about keeping things balanced. So I really do hope that helps. It was about 14 minutes. If you don't understand DKA, continue reading your book, or you know where to find me.